Welcome to the webinar from the pediatric urology, under the USI and the ISU. Today we have face-to-face with a legend, and we have a legend in pediatric urology, Pedro Lopez from Santiago from Chile. And we also have Dr. Luis Braga, who would be joining in a bit later. He's likely to reach the airport and he'll join with us. And we have our eminent national faculty, Dr. Hemant Patak, Dr. Ansari, Dr. Amila Albad, Dr. Chandra, Dr. Prasanna, Dr. Mallikarjun Reddy, and Dr. Rahul Kapoor, led by Anil Takwani, who is coordinating all these activities very regularly. And we hope this session would be very interesting. I will now invite Dr. Sabnis, President, Urological Society of India, to give his opening remarks. Over to you, Dr. Sabnis.
Thank you, Keshav, and thank you, Dr. Chawla. This is a wonderful program. And I must special Dr. Pedro Lopez for joining us and enlightening us on the pediatric urology. As we were discussing, the pediatric urology now is, we are giving a special section to the pediatric.
I think his connection is a problem. He's in Dhaka.
He's in the airport, sir. He's in the airport, yeah. Yeah, he's joined, sir.
Sabnis, sir, are you with us?
Yeah, I'm with you. I think there is some connection problem. Actually, I'm traveling. I'm in Bangladesh. But I must say that this is a wonderful program. And it is really a legend face-to-face because we have international speakers and who's who of your pediatric urology in India are all there today. So I'm sure this webinar is going to be very, very interesting, very informative and very educative too. So congratulations to you and all the best for this webinar. And Takwani is always a very dynamic person, and he has taken the brunt of organizing this webinar. And I'm sure it is going to be very, very successful. Over to you, Keshav.
Thank you, sir. Now, can I invite Dr. Arun Chawla, Chairman of the Indian School of Urology, to make his remarks? Over to you, Dr. Arun.
Thank you, Dr. Keshav. Greetings from Indian School of Urology, Urology Society of India, and warm welcome to all for today's webinar, Face-to-Face Legends in Pediatric Urology. I think the program initiated by Dr. Anil Takwani was Professor Anthony Corey in the last chapter, and today we have a very eminent faculty, Professor Pedro Lopez from Santiago. I think the topic which we have chosen is very interesting, the DUPLEX system and the URETEROCELE. As we all know, there are different school of thoughts on management on various issues in this topic. You have conservative management, you have incision. In incision only, there are different ways to do that. Again, different school of thoughts, whether to give punctures, smiling incision or different incision or section. Then again, the upper tract versus lower tract approach in the DUPLEX system. So it will be very interesting to listen to first the talk by Pedro Lopez, and then probably icing on the top will be the two cases which will be brought by our faculty and discussed by the panelists, including Dr. Hemant Patak, Professor Ansari, Dr. Amila Albad, Chandra Singh, Dr. Mallikarjun Reddy, and Dr. Prasanna Venkatesh. This topic is of interest to me also because of what I know is my first publication in any urology journal was on ectopic uterocele posterior valve. Both the condition of different embryological region. But at the same time, I remember any case in pediatric urology comes, it is examiner's favorite question, Wigert-Meyer rule, the classification of uterocele, different type of classification. This always is something like a favorite question of all the pediatric urologists. So in all, I think it will be a very interesting program, both for the residents as well as the member interested in the pediatric urology. I congratulate Dr. Anil Takwani for this program as well as all the members. And again, the best wishes for happy learning to all our members. Over to you, sir.
Thank you, Dr. Arun. Now I would invite Dr. Anil Takwani to take over and moderate the session. Over to you, Dr. Anil.
Anil, before you start, I must say that any program in pediatric urology in India is incomplete without blessings of Dr. P.V. Venugopal. And PVG sir is here today. Even at this age, he has taken so much of interest. He has done so much of pediatric urology to India, so much that he is aptly called as father of Indian pediatric urology. And today we also have his blessings. He is personally there logging in, and I'm sure he'll oversee and give us his comments time to time. So I must thank especially Dr. Venugopal sir. We are very grateful to you, sir. Over to you, Dr. Takwani. Anil, over to you.
Dr. Anil, are you with us?
Sir, I think Dr. Anil has lost. I'll take it forward, sir.
Yeah.
Yeah, please go ahead.
Okay. Good evening, everyone, and thank you all for joining in today. Thank you, Dr. Venugopal, sir, and all the senior faculty members from the subsection of pediatric urology. A very warm thanks to the Urology Society of India and the Indian School of Urology. It is also my honor to introduce Dr. Pedro Jose Lopez. He is fondly called as Dr. PJ, and he's the professor of pediatric surgery and pediatric urology in the University of Chile. He's also the head of the department pediatric urology at Santiago in Chile. He's the past president of the Chilean Society of Pediatric Surgery and the past president of Ibero-American Society of Pediatric Urology. Dr. PJ has specific interest in complex reconstructive urological pathology and minimally invasive surgery as a way of further development. He's also involved to facilitate the smooth transition from pediatric to adult practice by enhancing adolescent management. I think this is something that we also need to take forward. And one of Dr. PJ's career aims is to be at the forefront of this development in establishing the scientific basis and translating this into first-class clinical services. He is on the editorial boards of 5 journals. He has published over 45 chapters, edited 2 books, 2 academic websites, and has published over 120 papers and book chapters. He's also a well-recognized international speaker and has been a regular visitor to well-known meetings where he's been invited as a plenary speaker. He is an active member of 10 scientific societies and currently is on the board of 2 of them. A very warm welcome to you, Dr. PJ and Dr. Braga, for giving us this valuable time of yours. And we hope that this will be an evening of academic excitement. I now request you to please give your lecture on duplex system and ureterocele and overview. Over to you, Dr. Pedro.
Prasanna, 1 minute. Luis has joined from the probably airport. Luis, thank you very much for joining. Warm welcome to you also.
Yes,
Luis,
thank you.
Yeah.
Yeah,
And
I'm here.
thank you very much once again for making us possible this contact with the PJ, a very good friend of you. So yeah, you can go ahead, PJ, for with your lecture. You can share your screen, sir.
Thank you very much. Good evening to all, and good morning to all the friends who are watching us from this side of the world, and thank you very much for this invitation. I'm very honored to be, as I told you before, in my first time in India. So we will start showing you a little bit where I come from. This is South America, and you can see Chile is this long 4,000 kilometers wide country. And here are some pictures from the landscape that we have: the north, the south, Santiago, Easter Island, Valparaiso, and the lake zone. And the most interesting things are our people. So anytime that you are here or you want to come, you are all being invited. This is my hospital. You are all very welcome there. And if you want to know as much from us, here's our website, and you can scan that, and happy to do that. So today I will be asked to speak about duplex system, URETEROCELE, and then we will start talking about some random thought and ideas about these topics. Hopefully we will do this in less than 35 minutes, so we will have some time for the discussion of the cases that Anil and his group has prepared. Just to start, if you need to fill some kind of program in any part of the world and you have a 3 hours gap, just get a duplex system panel. It will last forever. Everybody has an opinion, everybody has a different approach to do that. It's the same like this picture. Someone can see the young lady, someone can see the old lady, some of us can see both of them. So with duplex system, it's more or less the same. Just in simple words, this is the law of the duplex system, where we have an upper pole and an lower pole system, where the lower pole will be found more with reflux, and the upper pole probably will be more dysplastic than the lower pole. Then it could be complete or incomplete or bifid, and you can see that most of them are probably incomplete. So complete is a rare system in a duplex system. If you have a UTI, probably a 4% of them will be a duplex. Duplex plus UTI, just go and look for the VUR, and maybe a 20% more or less has been a family predisposition. How you can diagnose this could be incidental, most of them, but today with the antenatal diagnosis or the investigation for UTI, or in some, especially girls, investigation for incontinence, you may find the duplex system. When you have a duplex system, you can have these 3 scenarios: the VUR, an ectopic ureter, or an obstruction. Sometimes just the VUR, sometimes just the ectopic, on another kids just the obstruction. Most difficult, you have the 3 of them. Don't forget, you can have none of them, just a duplex system, normal one. So this is to be discussed with all of you and the people who are watching us, because when you have a duplex system, how can you approach that? You can go to the upper pole and do some surgery there. You can do in the middle and do some pylo-ureteric or pylo-pylo anastomosis. You can go to the lower part of the system, and then you can do some work on the uterocele or uterostomy or other kind of stuff, and you can do a uretic anastomosis. So as you can see, the approach of this is not black and white and will depend in a lot of different factors. So which one of these should we take on? It will depend on the function, if we have or not VUR, and the patient, age, gender, family, etc. Don't forget the surgeons and the beliefs of the surgeons or the team who is treating the children. So let's talk about the function. If we have some function and we have good function, probably what we need to do is nothing, or sometimes not. But it's more easy if you have a good duplex system who has 2 poles with function. As you can see here, you can see the upper pole with less function, and here it's nothing in that part of the kidney. So then the question will be, should we save that part of the kidney or just go and take it out? So let's talk about a little bit about that. So if we take the function, not very good function, then we can to the surgeons and the belief. So some of us could do an eminephrectomy and said, you know, there's nothing there, you just go for that, it will be just problem, take it out. And eminephrectomy, either open or lap, it's not, for me at least, a really nice or easy surgery, because you need to find where is the right ileum to that pole and to don't compromise the lower pole. So this is an open one. You can see the 2 poles there, and then here you can see the line between both. Not always it's so simple as it can see here. And then after that you can see the lower pole and the upper pole that has been removed. So there's no clear limit between the upper and the lower pole, so you can have a dissection nice and clean there. Sometimes my guess or our guess from the team is that you will lose some function there because you cannot see clearly one and the other. And it's a stressful surgery because you are compromising, or you may compromise, the lower pole and the whole kidney at the end. And if we are doing open, don't forget about this. That means that there is a scar at the end, and sometimes the scar will grow up with the child. And we did some study with the pyeloplasty scars. We call all the open pyeloplasty that has been done 3 years and above. And you can see that the scars done by a pyeloplasty, a tiny scars, grow with time. So just have that in mind, because once the issue has gone, so you fix the problem, either you remove the pole or you did the pyeloplasty, then we will have an aesthetics issue in the long term. So what about the minimal invasive surgery? That's the new way, or it's a way that we can do it. In our hands, this is the position. We do a transperitoneal approach. Some people do by retro, but I think it's more difficult to teach and more difficult for the pediatric surgeon that we are used to come to the trans. So in an upper pole heminephrectomy, you just detach the whole hemicolon from that side, and then you have to look for the ureter of the upper pole and follow that ureter until the top, get behind the ileum, trying to avoid any damage to the ileum and the vessels that will remain in the kidney, and then do the heminephrectomy in that tiny space. So you can see here that we are moving the upper pole ureter to the other side of the vessels, and then when you have it, you have to identify really clearly which are the vessels who are coming to which pole. And here, as soon as you get that, it's getting more dark and blue, and then you can remove this with either the hook or ligature or the other implements. So it's not a really nice surgery, I must say, and sometimes you can have some issues with the lower pole and compromise that. So the question here is, how much harmless could be this surgery at all? So we review all our heminephrectomies in a 2-year follow-up who has pre and post scan, so we can see what happened with that function. So we are able to get 8 patients with that age and a follow-up of over 2 years in a median of 7.5 years. And we were lucky to have 4 opens or 4 labs. So that's more or less a random study. So the pre-surgery was nearly 40, and the post-surgery function of that kidney was nearly 30. So we lost in that kidney a 20% of function. So it's not just harmless less to do that. And one of them was a nephrectomy in an open one, that I would thought that we were pulling too high out of the kidney, out of the body to do the surgery. So we have some kind of damage to that ileum, and at the end we finish with a nephrectomy. This with the function, it's not new. You can see that has been published before. And why we're doing this surgery, that's a good question. Somebody said that could be hypertension, or that you can have a moiety there that maybe will develop in a malignancy, or concern, family concern, medical concern, patient concern, not sure. So the question is, do we really need to remove that pole? Actually, we don't know, and we think that we don't have to do it. So we start doing some kind of joint between our upper pole and the lower pole function. And at the beginning, we start in the upper part of the body. So we do an incision, we identify both ureter, and we did a pylo ureter anastomosis in the upper part of the body. Then we start doing this laparoscopic, and as you can see here, we identify both ureter. In this case, there was a stent beforehand settled, just to be sure that we are sure which ureter is from which pole. And as soon as you have both ureter identified, you will prepare that to do an anastomosis that will be end to lateral side. Laparoscopic, even if we are doing here an outside knot, it's a challenging surgery because knotting in a tiny space with really fine tissues, it's not very easy. So from this side, you can see that we are able to do it. Some of the patient, we tried to do a robotic and it was more complex because of the environment, because we are not having a robot in our hands as we used to do. And even if the results were very good, and you can see here the pre-surgery one to the post-surgery one, and we're able to publish this with our results, with good results, we're asking ourselves if this could be in an easier way to do it, because laparoscopic, not everybody was able to do an intra-body knotting. So we were able to come across this UU anastomosis in an inguinal approach. The people from in that part was Juan Carlos Prieto with Snowgrass in Dallas doing this at the beginning, and you can see one of the ureter identify and the other ureter identify, and then you do a ureteric anastomosis in a terminal lateral way in an inguinal approach. So even if you have this kind of disparity between a big upper pole ureter and a small lower pole ureter, you were able to do this surgery in an inguinal approach that aesthetically at the end and the long term will be much better. So this is one of our operating notes, and you can see that we are doing here the lateral ending, and we put a stent across the anastomosis. I know that there are some groups that do the stents just in the lower pole, and there are other groups that they don't do a stent any time. So we review our series in 13 years with 2 years of follow-up, and we were able to do it being less than 1 month to older childs in 19 patients with a 6.4 follow-up. And you can see our timeline, how we moved to the high approach, to 2 labs, and to the lower approach, and we were moving our approach to an inguinal approach more easily and more comfortable. So we have 1 urine leak and no obstruction in 2 years of follow-up. And then we come back to our original question. Does this surgery save the kidney function, or rephrasing that, does not affect the kidney function? So we review our series with a pre and post scan with the pre and post surgery again. And if you remember what we did with the nephrectomy, here we didn't have much function loss rather than the one that we was there as a moiety. So we're happy with this. It was feasible. The only thing is that because we leave a stent in, we have to have another anesthesia. That could be an issue for some groups. We were able to publish our series with 30 units in a long-term follow-up, and we have only 2 reduced in these 40 months. This is not new. You can see that in the early 90s, Foley's published that, and there came a lot of groups publishing this. And today we're being part of this study with other people reviewing over 150 patients to see the long-term results of this technique. So, of course, we have pros and cons, and one of the main questions is, are you compromising the good kidney because you are joining a bad kidney with the good kidney with this surgery? So we again review our series with 1 year follow-up in scans and renal scans of the both moieties, having a look closely to the lower pole function and what happened to the lower pole kidney. So in a 28 patients, 1 was bilateral with a 1 month and 36 months of age as average and a long-term follow-up, what we saw is that the lower pole didn't have an extraction, there was no new dilatation, and we didn't have any kidney function. So for us, this kind of surgery, it's a minimal invasive surgery because doesn't mean that we have to do it with laparoscopic. It means that it's a minimal aggression to the tissue and the child and with good results. Has any further step in this kind of surgery? The group of Toronto published this series and this technique long term ago, and Armando Lorenzo, who is outside of the box thinking and always have new ideas that we are happy to see and to see what's going on. He was saying if we clip the upper pole and leave it there, the upper pole will die at the end. And it sounds a very good idea, and you can see here his picture from his series showing that the upper pole was shrinking in the time and was all right. The problem was that some of these patients, either in Toronto or in other part of the world, some of them developed some UTI, nasty pyelonephritis. So we are waiting for Armando Lorenzo to show us the long-term follow-up of this series. So coming back to the question that we moved at the beginning, should we save that or just moving out? Probably in our group, we are most trained to just leave it there and try to save even if there's no function there because of all the reasons that we just explained. It's feasible to do the UAU anastomosis. We have good results. We could have some kind of cost because we have two anesthesias if we have to remove the stents in the long term. It's easy to learn and to teach, so any of other registrars are able to do it in few cases, and the most important thing for us, it's best for the patient. So why we don't move to the lower part of the upper, to the urine tract as the uterocele? We know that the uterocele is some kind of dilatation of the bladder mucosa of the upper pole ureter. So it's 1 in 4,000 newborns. It's more predicted in females, and it's ectopic more than intravesical, and we have a 10% that is bilateral. We can classify this in simple, that is called also as the adult uterocele, no duplex, just uterocele, or joined with a duplex system. It could be ectopic or normotopic, intravesical, extravesical, and then we have the big seco uterocele that will have a bilateral problem. The presentation could be antenatal, most of the case today, or after a UTI investigation, or because we see some kind of dilatation, or sometimes in a newborn we can see an introit mass. Don't forget kids with sepsis or some kind of kidney BOR or obstruction that has to be studied, and then you will find the uterocele. We can see the uterocele in an ultrasound like this, simple, beautiful, easy to see, or in a VCUG that you have to be aware to fill out very slow, so you will allow the uterocele to show you before collapsing because of the contrast with filling out all of the bladder. Some people do MRI, it's not our choice, but with any reason, and you can see the upper pole dilated here and then coming to the bladder with the uterocele. In a live aspect, you see the uterocele here in the other meatus, and if it's open, you can see it there with the open bladder. This is a cystoscopic view with a uterocele being there in the bladder, and see the other meatus for the other part of the kidney there. Introit mass could be not so big at that, or something like this that you can see the whole mass coming out and you have to rule out another diagnosis. Because we are surgeons and we would like to see if we need to fix this in any way, sometimes you can do this uterostomy, and you see here the double system here and two uterus here, and just one coming to the bladder and to the distal part. And then you have a uterostomy to come out, and you are running out of the problem and leave the uterocele and the other issues when the kids it's either not sick or bigger and could afford other things. If we need to another approach, we can go to the uterocele itself rather to the bladder or in endoscopic way. If we do endoscopic way, this is our setup to do endoscopic way, a 9.5 right angle cystoscope. We use endohel for the end. This is the patient position for a big one, and this is the patient position for little babies, that it's most of the case, and you can see that it's in an upper position because we put some kind of pillow under that, so there's no legs falling down. With the unskillful hand, I like to have it in another table so there's no shaking with the cystoscope when you're working there, just to punch this, to do endoscopic thing, or if you have to do an endoscopic injection for the VUR. So your unskillful hand is steady and you can work with the other one. Then for the irrigation, this is a trick that we use. Use your assistant to clamp and release, and you don't have to move the instrument in the cystoscope, so will not move in the inside. Small moves on the outside are big smooth moves in the inside. You can have different kinds of instrument to do that. One is the cold knife. It's good, but on my view, they leave some bleeding at the end, and to be honest with you, I don't like much the bleeding. Then we can start using some coagulation. One is the baggie. The baggie is the this kind of bowl that make holes there, and with coagulation or cutting, both of them, you can just go to the uterocele and start doing some punctions on the uterocele. The hook, it's another instrument, and the good thing about the hook is as soon as you get inside the uterocele, you can use the same hook to just get a bigger hole so you can decompress uterocele easier. You can use the coagulation so you don't have any bleeding, but don't forget that you can use the cutting setting as well and could be useful in this kind of instrument. Today, this is our preference, the laser, because one, you can have this nice Luke Skywalker light that you can see where you're doing the smile. Second, the coagulation or the heating to the uterocele, it's not so big as with the coagulation and the hook and the baggie, so you can just control much better where you're doing either the smile or the holes. And then you, or for us, it's good to see how big was the hole that you did. One could be one of the grasper, the foreign body grasper, and then you can open that inside the uterocele. The other possibility is just you go with your cystoscope inside the uterocele and start to navigate that ureter to see if there's anything else there, or you need to do a little more bigger hole. For us, if you're able to put your cystoscope in, your hole is big enough. Be able to don't do the hole too much in the upper part of the uterocele. Try to do it more lower, so either you will avoid the VUR, the novo VUR that probably come after the puncture, and you will avoid to have a new settle and a new closer. The guys from Toronto again has this nice idea to just puncture under ultrasound, so you can see the image here. And the idea of them is that you can see your puncture under ultrasound and you avoid to go so deep, so you go to the other part of the bladder and go to the posterior part of the bladder wall. Haven't been there, haven't done that, but it seems a good idea. And then you can check with your ultrasound how the uterocele decompress in a nice view, and you can see how the urine's coming out of the uterocele. So because we're surgeons and we like to fix things, I'll show you one case. This is a 6-month-old febrile UTI girl. You can see the right kidney in the upper part of the screen, and the lower pole is the left kidney. The uterocele is here with some pus or debris inside of the ureter, and somebody asked for a renal scan, and as you can see in this image, it's obstructed. So what we did was a nice puncture, and we decompressed that endoscopically, and you will see how the pus is coming out to face you in the cystoscope view. This was both treatment for the infection and treatment for the obstruction. So in a VCUG done later on, you can see there's no uterocele there, there's no obstruction in the follow-up, and if you want to focus which is the best approach for this, either small hose or just remove a big piece of the uterocele or a smile, there's different approach of different people. So any of them, it's fast, quick. It will be a treatment for the uterocele, and if it's infected, it's a day surgery, and you can do it in every age. But do we have any difference if we do just holes or a smile in the lower part, or we remove a whole one? Let me have a review of the literature with you. What are the risks of that? One of the main risks, if we could do some kind of novel VUR in that kind of ureter, do we need a second procedure after this? That was the second risk. And what happened with the bladder function? So it has been reviewed long term ago, and you can see that the risk of a new VUR after a puncture, it's more or less between the 15 and the 50% of the cases. Most of this VUR will go away by itself, or it will not be a clinical issue. The second surgery, and in some of these publication, it's not longer than 50% of the cases. And if we do an incision or a puncture, probably there's no much difference in the long-term results. But if we compare that, and this is a paper published in 2011, compare the puncture and the incision, they come across the conclusion there's no risk for a new procedure if you do some different holes or just a smile incision. But if we take that in this systematic review, if we do a laser punction or electrical with the baggie or the hook, there's some difference with the VUR, and there's some difference also with the needs of a second procedure. So in this paper, that was a systematic review, unfortunately with not many papers, there was 6 papers, not more than that, the laser seems to have less VUR on the long term, and the second procedure seems to be in a low risk with the laser than with the coagulation. Why? Probably because the coagulation make a scar that fall later on, so your hole is bigger than what you see at that. Just to have in mind, in this review, there was a bias, or we can say there was a bias in the review, because people who do laser tend to say that the laser is best, and people who do the coagulation tend to say that the coagulation is better. So as an overall, the endoscopic treatment is a very good option. It will solve the problem, and it will facilitate everything if we need to do a second procedure. What happened with the bladder function? The only paper that I come across is this one from Alain Gomeni and the people from Paris, that they did some study comparing groups that in a long-term follow-up with urodynamic assessment, punction versus just go and fix the whole thing with the bladder surgery itself. And their conclusion was that the endoscopic treatment will not get so much bladder dysfunction as a secondary bladder surgery. So if we start to just recapitulate everything and start to concluding, what we can say is that the UTI risk in a uterocele patient with antibiotics is less than 10%. Asymptomatic people maybe could be follow-up and don't need anything. A non-functional moiety could be left there and just follow up. and less than the 40% of the VUR will develop a UTI. On the other hand, incontinence is rare, so it's just for ectopic ectopic ureter in a girl. Endoscopic could be the treatment for the uterocele, and if we need to do a reconstruction, just consider the whole package: excise the uterocele, reimplant, and maybe do a bladder neck reconstruction. If we need to do some kind of algorithm and follow-up decision, you can see here that most of our follow-up, it's an asymptomatic or no symptomatic. You just follow this and probably do nothing. There are few who really need some kind of intervention. I can imagine that we have talked a lot, so let me give you one last case of an example of the myth that could be this approach for DUPLEX system and uterocele. This is a 6-month girl who has a 2-month growing problem and start with vomits and diarrhea in an afebrile. You can see the right kidney and you can see the left kidney in this ultrasound. As you can imagine, there was some pus on debris here near the bladder with the left one, and the ureter of the left one has some issues inside that, as we saw in the girl before. So what can we do in this case? There was some discussion and people said maybe what we can just watch and see. We can start with antibiotics and just some bladder catheter, or antibiotics and surgery. What we did was a cystoscopic view because we were concerned about this pus in the uterocele, and here you can see what we found. This was one meatus of this left side duplex system, and when you're coming out, you can see the uterocele there, and it's a sick uterocele that is sitting there in the bladder neck. So at this point, the question was, what do we do now? So our suggestion, impression of what we did, we just did an intravascularization of the whole roof of that uterocele. So we open widely that part of the uterocele, creating a huge meatus that, of course, maybe will give us some kind of huge VUR, but at least we will remove the obstruction part of the equation. So then we went to literature and we saw here the guys from Madrid, Jose Maria Angulo, who has done that and has published that with very good results. In our case, the follow-up, you can see that now the uterus is still dilated, but it's clean, and a couple months later, still dilated and no infection and no problem at all. Then we did a VCG, and you can see, as we expect, a huge reflux in that side of the huge meatus that we open. So the question now was, what we do now? We will continue antibiotics, we leave it there, or we try to do some definite results. So the findings that we did in that cystoscopy 5-6 months later, you can see that in the bladder neck we didn't have any problem at all, and in the meatus of that upper moiety we saw a huge meatus. We compare the one from April when we did the surgery and the one from September now, and you can see the difference here. We compare the meatus there, and you can see how nicely everything was healed, and you cannot see any drip. So we don't have the uterocele problem, we have the VUR problem in a DUPLEX system problem. So what we decided to do was to inject that lower meatus as an obstructed way. So we closed that with a bulking agent, not trying to avoid the reflux, just to get really obstructed, to avoid a further problem in that stump that we can leave there. And after that, we did a UUA anastomosis, as you can see there. So we have the upper pole in the distal part just obstructed, and then we combine a UU anastomosis there for the upper and the lower pole. And as you can see here, the function and the aesthetic results are as the bikini line, and there's no scar. So at the end, we were really happy with these results. Just to sum up and to finish, we can say that we try to save the kidney function as any pediatric urology in any of these possibilities. To be conservative, it's a good option. We don't have to go and do surgery in any case. Because this is a really different approach for different kids and different scenarios, it's really difficult to just go for one recommendation and more difficult to do this recommendation in evidence-based medicine. And our suggestion is to treat every patient as a tailored approach. So what do the patient needs? That's what we need to do for him or her. As Sir Davis said long time ago, there is ordinary pediatric urology, and then there are the duplex systems we are discussing today. Thank you very much for your time and for the invitation to share the thoughts and ideas with you, and I'm happy now to discuss the cases and if there's any other doubts about this presentation.
Thank you very much, PJ. An excellent description about the duplex and the URETEROCELE. And very quickly, we are moving to the interactions. In the first segment, I am presenting a couple of cases. And with me, Dr. Amilal Bhatt and Dr. Mallikarjun, and probably Dr. Ansari, if possible, you will be joining to interact with you. I will be putting this scenario very quickly. There are many viewers are there. They can also put their questions into the chat box. One of us will collect the good questions and we'll put to you at the end of our discussion. So can I share my screen? Yeah, please. Okay. So PJ, once again, thank you very much for accepting our invitation. And very quickly, I will be giving 3 scenarios, which probably you have discussed very nicely. But just to make very much clear into the minds of the viewers, many are general pediatric general urologists. Very quickly, we'll go through the 3 scenarios. One is this. This patient referred to me from Bangladesh at the 10th day of the birth. Nothing was a problematic during the birth. There was an antenatal detection of left side hydroureteronephrosis and something like URETEROCELE into that. And this is the creatinine, which was normal, not normal, it was 0.73 at the 2nd or 3rd day. And culture was negative, which turned out on 2nd, 3rd day. Very quickly, I'm moving. This sonography was done on 2nd day. There you can see a very huge hydronephrotic upper moiety. This is a lower moiety, right? You can see even in another plane, entire ureter was dilated. This is a lower ureter, and there you can see the cyst-like structure into the bladder. So probably URETEROCELE. So as you said, we got almost every information into that particular sonography. And this is something about the right kidney, which was normal according to them. But unfortunately, on 2nd or 3rd day of the birth, this CT scan was done. So we would like to condemn this practice. And through you also, we would like to give a very strong message against the doing CT scan in a child of a 2nd or 3rd day for this kind of a thing. There, but you can see just that this kidney was, this upper moiety was very poorly functioning, but we cannot comment as such anything like that. But you can see here there is a URETEROCELE, and then the child was referred after this investigations to me. We just keep on doing sonography. So this is 1.5 month sonography. There you can see a little bit of hydronephrosis regressed. Child was doing perfectly well, no episode of infection, voiding properly, no problem. Urine remained normal, no infection. Culture was negative again. This was the MCO done almost at the end of 7 months. There you can see this URETEROCELE-like structure there with the full bladder. And here you can see probably this URETEROCELE is everting maybe, or I don't know, but this is the thing. There was no problem with the emptying of the bladder. There you can see in the post-void picture. Then this was the renal scan done at that time. Upper moiety is not showing any function. Otherwise, no obstruction and on lower moiety on the left side as well as the right side unit completely normal. There you can see in this particular scan. So in short, the child is of now 15 months. Just 3 days before communicated with the father, is asymptomatic completely on antibiotic prophylaxis. He's taking cefixime 50 milligram. Night serum creatinine is 0.46 right now. No voiding issues, gaining weight and height, and they want to continue with this still for observational kind of treatment. So here patient is on continue, means parents want to continue with the observation. So let us stop here. You agree that whatever we have done in this child by this time, one, and second thing, as the child is doing well, the parents want some more time. I wanted to even post the email because they permitted me to discuss this case. No anonymity is also required, but still we have kept the name anonymous. But there are. Do you agree there are some chances of a regression of this upper moiety, which we generally see in the multicystic dysplastic kidney? But a couple of the authors have seen that the cystic renal dysplasia associated with the duplex moiety, upper moiety, can also have some involution, and over a time it disappears. So observational protocol can be justified.
Thank you, Anil. So what you have here is a 15 months old baby that has been through a lot of investigation with no clinical issue. So there's no infection, it's growing all right, it's still on antibiotics, and you have an ultrasound and tests that show that you have an dilatation in the upper pole and some uterocele in the bladder. So on our view, probably will do nothing. Maybe the only change that we will suggest is to stop the prophylaxis antibiotics and see what happens. So if you stop the antibiotics and the child has a UTI, your balance was a tiny balance, and then you may need to do something. But
Yeah,
if you
agree.
stop the antibiotics and nothing happens, we will just follow up this with ultrasound and leave it there.
So we decided to do stopping the antibiotic prophylaxis by the age of 1.5 years. So almost he is reaching to that age, and you are perfect. But suppose child do not develop any symptoms, will you continue with the observational protocol treatment, or you will go for a puncture?
Why will do a puncture, Anil? There's no problem. We just have a dilated ultrasound showing a dilatation in an upper pole.
Do you have any long-term studies or long-term experience that over a time in a transitional urology, when they become adult, they develop I have seen, because I am doing also a couple of missed cases of adult urology. I have seen previously that they came with the stone formations. They come with a line of stone which is formed into the non-functioning duplex upper moiety. Do you think this is possible, which we are probably exclusive pediatric urologists are not saying?
The answer is yes and no. We know patient that has been followed up in the long term untouched, but most of the cases that are today over 15 has some kind of surgery when they were born. So the non-touch or the observational therapy, it's in the last couple of years. So probably we need to wait for another 10 years.
Okay.
Having said that, we have some patients, Anil, that we have been follow up, and we can see how the uterocele start to decompress and the upper pole moiety it start to decompress. Yes, there could be some stones at the end, but you have seen the patient who came to you with a problem. We don't know the patient who are out there without any problem.
Perfect. Very clear opinion. So you agree that it get decompressed on its own, and there can be some kind of involuting sort of thing with the upper moiety, which I have probably quoted here, which was published in 2011 by this Paul. Anyway, but you agree But last couple of words regarding this case, regarding the CT scan, which was done on the third day of the life.
I will not ask for
I
a CT
think it is a
scan.
very unfortunate. What we think, we in the USI, Urological Society of India, we are trying to make people aware to go away from the CT scan in pediatric urology patients, specifically in these sort of conditions. We only now recommend CT in couple of difficult cases of stone disease, rather than, other than that.
I will ask the CT scan if you need that information to do something. You already know from the ultrasound that that upper pole moiety, it's not functioning. So you don't need a CT scan to confirm that. If something happened because the child is infected or has pus or whatever, maybe you need a CT scan because you need to take a decision to take the child to
But
theater
if
or
you have
whatever.
enough of information with the good sonography, which I have shown you in a couple of sonographies, you have almost every anatomical information. Probably CT is too much of a radiation in a small key. At the most, if you want, I think the why not MRI instead of CT?
I will go for not a CT or MRI, probably a DMSA scan will be enough because the only thing that you need is function. You
No,
don't
function
need,
we have done. See, function here we have done. This is just a
yes,
CT they have done for anatomical confirmation, which I think which is something very overdoing, subjecting the child with the too much of radiation, because child is undergoing MCU one, which is almost compulsory. Second thing, renal scan, again radiation, and third, when you are adding the CT and specifically CT IUP, then this is too much of a
I
radiation in a very small key.
I will not ask for a CT scan in this kind of child
Perfect.
unless you are thinking in an ectopic ureter in an older child that you are not able to see by the CT, by the ultrasound, whatever. But if not,
So
just leave it out.
So I'm now inviting Professor Amilal Bhatt to make a brief comment or any different kind of a
Yeah.
thought process in compared to PJ.
Thank you, Anil. This is, I think I have my clear views about it. There are only two things, because you want to have the anatomical details. You have anatomical details with the ultrasound, very nice. Second one is that if you want to have, and if the child is the symptomatic, means the febrile UTI, then go for the functional one. If there is obstruction, as you have shown, renogram. After renogram, I have my reservation even for VIU. This one, VCUG. VCUG only when the child is symptomatic. If
Perfect.
the ultrasound is showing the regression in the both ureter as well as the dilatation, nothing is to be done, to be observed. And I don't think that this child needs any intervention at present. And as far as prophylaxis, also the child never had any symptom, so maybe that intermittent antibiotic prophylaxis. Otherwise, I'll wait even for the
Okay.
prophylaxis.
So very fortunate that we have a very much uniform opinion in a patient with the duplex with the ureterocele. I'm very happy and very clear message. If the child is asymptomatic and having a poorly functioning kidney, doing fantastic, nothing, no more interventions are required, and we can stop antibiotic prophylaxis very
Yes.
much comfortably when the child is almost reaching to the toilet training or 1.5 year or 1 year of age. And secondly is that we can avoid as many as invasive or radiation involving investigation. So moving to the second case very quickly, there the scenario is almost same. It's a 1.5 year female child came with the sepsis. That's the only difference. So I'm moving very quickly. 1.5 year child, since last 6 months, 3 episodes of febrile UTI. Recently, means febrile episodes, but not diagnosed with the UTI, unfortunately. But last episode was UTI, recognized with the UTI. Another sonography multiple times, but not very good sonography. Then creatinine is 0.43, urine culture positive for E. coli. Urinary stream is good, no voiding issues. So this is once again sonography. This is the renal level USG. There you can see upper moiety dilated. In another view, you can see axial view, and there you can see ureterocele and couple of internal echoes are there probably, and this is a bladder. And then this is the MCU, as PJ said. You have to feel it very slowly. In this patient, they could not demonstrate easily in initial plates because they filled bladder very much, and that's why they could not see. But later on, once the some kind of a time passed, they could see the cystic area, no reflux again. These all patients are not having reflux, and this is a functional study to document the upper moiety function. Upper moiety is not practically function. You can have a you can see that here the split function is given for the upper moiety, which is hardly 11%, and but they have written that it is almost not non-functioning or not having any function. Lower moiety is perfectly all right on the left side, means affected side, right side, and the left kidney is also perfectly all right. Now here the difference is that it is not asymptomatic. Child has come with the 3 episodes of the sepsis. Malikarjun, I want to bring you, what is your choice in this patient as a treatment?
No, now we have a child with a ureterocele with infection.
Yeah.
First and foremost, I would look at decompressing the ureterocele and then take it forward from there.
So how would you like to decompress? By cystoscopic incision or by UU?
No, I would do a cystoscopic incision, because after a cystoscopic incision, you may not even have a reflux in all cases. You may not need to do anything. The child may be okay. You have decompressed the ureterocele. There is no obstruction. There is no reflux.
Okay.
No, probably the child would go be.
Yeah, perfectly agree. And would like to bring the PJ here. PJ.
Yeah, Anil, before
cystoscopic puncture
PJ
is the choice. Yeah, please go ahead.
Anil, before Dr. PJ comes in, let us go back to Armando Lorenzo's paper, where he clipped the ureter, and then he sees that the thing stabilized. So it is like that the ureter is it's an obstructed ureter. Until unless there is a problem, I think we need to keep our hands off for the whole process.
What is my point against the Armando's paper is that if the child is asymptomatic, like first case, where is the need of even clip? If the child is perfectly well, all right.
We leave
now,
that.
In infected cases,
we take
you
the end
cannot
result.
clip. Yeah.
No, we are taking the end result. We are not looking at why he has clipped. Let us leave the indications apart. Now we realize that by clipping or leaving an obstructed ureter, we are seeing that particular system slowly collapses on its own. So we really need not do until unless it is causing a problem to the child.
Perfect,
or problem to the kidney if it blows up and then cause something. So here, do the simple, get the maximum. So the simplest thing is to do a simple cystoscopic puncture.
Absolutely agree. I think that means I can conclude your comment that you agree with the investigations done so far, and you are proposing the cystoscopic puncturing. Now, PJ, do you have a different opinion, or you will go ahead with the cystoscopic puncture?
Just to rephrase a couple of things about the case, Emil, we are talking about now, how old is the child?
1.5 years. She came just before 1 month with the 3 episodes of febrile UTI. She was on antibiotic therapeutic dose. Subsequently, she is on antibiotic prophylaxis, and she was then undergone all these investigations.
In our hands, even the cystoscopic endoscopic incision, it's good and will decompress everything. Our first option will be the UU anastomosis.
In this particular case.
So
that is what I wanted to have in face to face, because I was listening you at the Cincinnati. And it was a bit surprise for many of us in India, because for us the first choice is the cystoscopic incision in this kind of a cases, because the UU, if you do UU, you will be having also decompression of the ureterocele. But how can you be sure that with the decompression there won't be a reflux?
You cannot be sure.
You have a fear of a reflux with the incision, maybe.
No, you cannot be sure. And what the point that you are trying to make is that when you decompress the uterocele, the other moiety could have a reflux anyway that wasn't there because the uterocele was obstructing the lower pole ureterocele, the ureter. So in this case, particular case, girl, our first option will be a UU. Simple incision, retroperitoneal approach, doing the UU and coming out of that.
So what is
Having
the
in
problem
mind-
with the what is the problem with the incision?
There's no
Why
problem.
not incision? It's a very simple procedure, as you say.
Yes,
You do
it
an
is.
incision, and there won't be a reflux. Child recover very well. It's a daytime procedure, and you can keep the patient on antibiotic prophylaxis couple of months. Then the child is toilet trained. You can leave. You can just watch the child.
Yes,
Right.
yes. The possibility to have a VOR after the punction could be until 50, as we saw in the presentation. The possibility of a new VOR after the UU is less than that. So you need to keep antibiotics after the
And
endoscopic
another
incision.
argument against PJ is that it's a very poorly functioning kidney moiety.
Yes,
It's a very
I know.
poorly. Yeah. So why
I
not
know.
incision just and decompress and then watch the patient?
I haven't said that is wrong. What I'm saying is that
No,
our
it's
first
your
option
choice.
it's a UU rather than an incision.
So that exactly
Anil, one
Now
small
coming to
question
you,
to
coming
Dr.
to you.
PJ.
No,
No.
I'm coming to
One-
you. I'm giving you
no,
time
one
because
question
that
to
is
Dr.
what
PJ.
exactly the meaning of face to face. Malik, you can go ahead.
Yeah, Dr. PJ, I was just thinking that your option of a UU would be wonderful, that we probably take care of all the things. But how do we substantiate or we say we can go ahead and do a UU on an infected kidney? Because that's the most probable cause for the recurrent urinary tract febrile UTIs which that child is having. So would we like to put in an infected kidney into an uninfected kidney?
No, there's two different issues, Manil. One is that first we treat the infection, we come out of the infection. If you are in an emergency, if you have a pyelonephritis, if you have pus in the uterocele, go for the incision and come out of that. That's fine. If the child has been already...
Sorry to interrupt you. Do you agree that there are a couple of internal echoes are probably seen in the ureterocele?
No, that
Not
for
agree
me
much.
it's not.
I agree.
No,
I agree
no.
with you. No, not much. Yeah.
No, there's not much. If
No,
you
not
show
much.
me that,
But there were 3 episodes of febrile UTI. Yeah.
If you show me that ultrasound and the child is completely healed without infection, no UTI, no febrile symptoms, running or being normal, I will go for the UU. If you have a doubt of infection and you need to decompress that, I will go for the cystoscopy. And if you don't have a cystoscopy, you can do a uterostomy in the safest case for the savage of the thing. Not every unit has a cystoscopy, a child cystoscopy. You should have one if you call yourself a pediatric urology. But if you don't, because it's wrong, because it's not fixed, whatever, you can also, in a febrile, septic, with a pyelonephritis child, you can do a uterostomy and get out of that.
So I really agree with you also, because that was a surprise at Cincinnati to me also. But that is the point which we really wanted to discuss with you in this face-to-face segment. Here, as Malik advised, yesterday only I operated this case. We did. I don't want to run this video because we have shortage of time. But we put an incision. It drained very well, and really the urine was not appearing at all infected. And we'll see, and I will provide you the follow-up. And in my experience, so far, so in a couple of cases where I have put an incision, I have not required second procedure in this sort of situation. I don't know.
Let's go further for that. If you do an incision in this 18 years old girl, would you do or would you ask a VCUG after all? Or will you just stop antibiotics?
So what I will do is that I will be keeping her for 2 to 3 months on the antibiotic prophylaxis, working on her voiding issues, constipation, this and that. And once everything is addressed, I will stop antibiotic prophylaxis. If she develops a fresh infection, I will definitely consider her for MCU. If she doesn't develop fresh MCU, we don't do MCU. She develops no fresh ATI, we don't do MCU. Just for educational purpose.
Anil, I will add one more thing.
Yeah.
Anil, I will add one more thing for the VCUG. is anatomically, if there is no change, there is no de novo development of hydronephrosis, no increase in the size of the upper pole, with no symptoms of UTI, I think the VCUG would be defunct, and probably we can avoid a VCUG
We don't
in
do.
these
We don't
particular
do.
cases.
We only do sometime in educational purpose in initial our period when we started doing all these cases. But now we are only doing if this. Yeah, you can make your last point, sir.
Anil,
PJ, yeah.
Can I introduce you Francisca Jankovic from Chile, who is raising the hands, and I'm sure that she has a very good opinion on this.
Very quickly, because I will put very quickly third scenario, and
Yes.
thereafter we can also go. Yeah, go ahead. Go ahead.
Hi. Very quickly. It's just that I will say that I work with PJ, and when I first came to the department about 10 years ago, I said myself, I will never do a uretero anastomosis because I think that this is a wrong operation. And now, 10 years later, I will say that this is a very, very good option for this kid. It provides you an option to do just one surgery and solve all the problem. So I will say that at one stage, I was in the same position as maybe you are, like doubting about the benefit of this surgery.
I want to correct you that in India, we don't do much of the upper moiety excision. We either land up with the UU or incision. But in most of the time, patients appearing with the sepsis, we generally treat first with the incision and then we look later on. But in a couple of us, in our experience, we have not required even a second surgery with the incision. And definitely second choice of procedure in India, either it may be a complete ureterocele excision in that indicated case or UU. Most of us are agree with that in India. The practice, we are very much practicing UU. We are absolutely agree with you and PJ. So quickly introducing third case, the scenario is not much changed. I'm going very quickly. See here, you can see hydronephrosis of both the moiety, upper and lower moiety. This is a ureterocele, and there you can see no reflux. So the difference here is both the moiety are obstructed, and both the moieties are having some function. You can see here in the renal scan, which is a functional study, you can see at 2 hours there is a function there. Right now, here I go ahead with the cystoscopy. It was everting. I was not able to see. I was just able to see the ureteric opening of the lower moiety just on the top of the ureterocele, which is generally not seen, because in the first case, in a second case where I put incision, the lower moiety ureter was good enough away from the ureterocele. Here it was just sitting on the top of the ureterocele. So I decided to go ahead with this kind of a surgery where I excised the ureterocele completely and did a common C theme reimplantation. Here you can see the upper moiety, this lower moiety ureter is terminating almost into here, right? And so it was not that difficult. And this is the, just for educational purpose, child was being fantastic, but did VCUG to see the reflux persistent there or not, means new refluxes appear or not. And this is 11 year down, the follow-up with the sonography. There you can see complete disappearance of the hydronephrosis, and this is the bladder level sonography. So PJ, you agree with this management in this particular case? So we have a three scenario: one asymptomatic, one sepsis, and one both the moiety are obstructed.
Just one question, Anil. What was your explanation to have the lower moiety dilated?
Yeah, see, it was just very much over the you can say the upper part of the ureterocele. Most of the time, what I have seen in where the lower moiety is not dilated, the lower moiety orifice is quite away, which you have shown also in your presentation. And if we go a couple of these slides behind, I can show you the video where you can see the lower moiety ureter is quite away from the uterocele. Here, lower moiety ureter is almost just joining to the ureterocele, almost opening here. So that's the reason that I avoided the putting incision and not even consider UU, as both the moieties were dilated, and decided to go ahead with the excision and the common C3 implantation.
Probably the only thing that I will do different than this one is that our approach is an extra bladder approach. So
yeah, this was extra bladder. This was extra bladder. I approached extra bladder and then went inside the bladder to have a good length, because see, when you do common C3 implantation, I do believe that we have to do a good detrusor repair, and then you have a good tunnel, which should be at least a significantly means 5 centimeter sort of a tunnel to avoid the reflux. But I agree with you. I approach extravesical, and then subsequently I opened up the bladder, just lift up the ureterocele, which was within the bladder, and then repair the detrusor, and then the reimplantation done. So,
I mean,
yeah.
as one of our professor in pediatric in Chile, Francisco Sandon, used to say, good results are never been discussed.
Right. No, it's no, but I wanted to discuss with you that we in a couple of cases we do a complete ureterocele excision with the total reconstruction, lower reconstruction. So Malik, and quickly one short comment from Malik, you and Professor Amilal Bhatt regarding anything different you would have done in this last case.
I don't know whether I would have done anything different in a sense that maybe I would have probably taken a chance of decompressing the ureterocele endoscopically and then probably having a relook later rather than going ahead and straight away doing a common sheath reimplant, because common sheath reimplant in the best of the hands has got not that kind of results than like we do.
So we are coming
I probably would have opted.
We are coming very quickly in a Rahul's case that what can happen with the common sheath reimplantation. So I agree. Yeah. We'll take that comment very seriously. But that is what I'm saying, that it is a very difficult surgery. And
one more thing is, may I ask Dr. PJ, I think we leave this case for a second, and then what is your take on lower pole reflux with a normal upper pole in a duplicated system? The upper pole ureter is slightly lower on the trigone, but inside the bladder, non-obstructed, functioning, but then you have a refluxing lower moiety, which is about grade 4. So we leave the. What's your thoughts on actually dealing with these cases? Because lower pole is the maximum functioning part of the kidney.
Yes, it's a very good and tricky question, Malik, because most of the time you try to leave the lower pole alone and try to don't touch it because it's the functional kidney. So we have a couple of cases, and recently Francisco Reed, who worked with us, has one with the lower pole, huge dilated reflux there and nothing happened in the upper pole. So the discussion was either you treat that endoscopically and you just inject with a bulking engine, or you do a formal reimplant, try to get the most successful result for the surgery. And what we have done, it's you see that endoscopically and you see how the meatus of that is. If you think that it's a meatus that will able to you to do endoscopic injection with good results without trying to compromise that moiety, you just go for it. Remember that today we are injecting in reflux less volume that we used to inject 10 years ago. So probably it will be 0.2, 0.3, 0.5. All days, 10 years ago, 20 years ago, we inject 1.5, 1 cc, so it was a huge bulking engine. If you think that it's a huge and big meatus, that you need a lot of volume to get a good results, what we do there is to do a formal reimplant open way with our hands and go ahead with that. If you will go for the injection, be aware to have some kind, and this is something that we learned from our friends from Argentina, have some kind of a stent in the other meatus. So you will see where both meatus are before you inject. So you try to avoid that your bulking will obstruct your outward moiety in the upper pole.
Okay. So Malik,
Malik,
sorry to interrupt you. We have a very interesting case where probably your questions are there. So quickly, Rahul, you share your screen, and there are a couple of questions which you are putting. Probably these questions are there, and then we will be having a free discussions. So this is a very pitiable case where Rahul, quickly you can summarize this case, and this is a real life case. We are treating this case right now. We are dealing with this case, and how exactly to deal. I want a couple of opinions from the experts. Yeah, go ahead, Rahul, quickly.
Good evening, everyone. I'll just go through this case.
Quick.
Yes. So this is an antenatally diagnosed bilateral moderate to severe hydroureteronephrosis with a left side duplex system and a large ureterocele on the left side. Bladder was distended and there is poor emptying noticed. Though the amniotic fluid is normal and the child was delivered with at the full term by a cesarean section. Serial serum creatinine was done initially.
Change your slide, Rahul. Rahul, are you changing your slide or not? I'm not able to see.
They're changing?
No.
No? Oh, okay.
No.
Just a minute. I'll just share it again.
Share again. You can share again.
Are they changing now?
No, I think you
No,
have a
no,
no,
yeah.
no. Now it's okay. Perfect. Go ahead.
Okay.
Go
I'll
on to
go
the
with
full screen mode. Go to the full screen mode, Rahul.
Okay, sir. Okay. They are changing, sir?
No,
No.
changing, but you have to make a full screen. It's very easy.
Now I'm making full screen.
No.
No.
चलो कोई बात नहीं, I think continue.
कोई बात नहीं, you change.
So I'll keep it in this format. Is
Yes,
this
yes.
a-
Yeah, keep
Yeah,
it in this format. Yeah, go ahead.
So just to basically start, the child is antenatally diagnosed with a bilateral moderate to severe hydronephrosis.
No, it's okay. Perfect.
That is
Go
done.
ahead.
Now the serum creatinine was done, which was showing a rising pattern. This child was not in sepsis, but she has voiding difficulty. And the MRI was done on day 1, which shows same thing. Right side, there is moderate hydroureteronephrosis with obstruction at VUJ. Left side, there is gross hydronephrosis in both the moiety with a stenosed prolapsing ureterocele of the upper moiety. So the child was taken for a decompression of the ureterocele surgery on day 6. On day 8, and on the follow-up ultrasonography, the ureterocele is still seen. So the child is taken again after 3 days. And then the repeat sonography shows that the ureterocele is completely decompressed. So 2 surgeries were needed to do a complete decompression. The child was followed for the next 1.5 years. She was asymptomatic. Routine sonography was done. The dilatation was stable. The child was, this is an micturating cystourethrogram, which is done on 9 months and shows a smooth contoured bladder with reflux on both the moieties on the left side. And notice there is no reflux on the right side. The DMSA scan shows that though there are cortical scarring on the left side, right side is normal. So child was taken at 1.5 years for a robotic ureteric common sheath extravesical reimplantation. And now the story changed. She suddenly started having a worsening upper tract, both on the right side, which has stabilized now, and on the left side also. And she started developing febrile UTI. This is a sonography. And the sonography shows that now there are multiple low-level floaters on the left side. And if you can notice, there is a mild hydronephrosis on the right side. I am stressing on the right side again and again because in the corresponding slides, we'll see the progressive deterioration on the right side also. This is a CT scan, which is done at 2 years. And if you notice, this is a reconstruction, which there is no, the lower end of the ureter on the left side is not seen actually. The child is now taken for the 4th surgery, which is now a left open transtrigonal Cohen common sheath ureteric reimplantation at around 26 months. That is around 8 months after the 3rd surgery. The story remained the same. She developed recurrent UTI, febrile UTIs. The right side hydronephrosis worsened. The bladder started showing a lot of trabeculations, and the left side hydronephrosis also worsened. This is the VCUG, which is done now when the child is 5-year-old, and you can see the trabeculated bladder and a gross reflux on the both the moieties. And for a comparative, I have this is the VCUG, which is done when the child was 9 months old. We can easily notice that the contours of the bladder are very smooth in the previous one. The DMSA scan shows now that there are photopenic area even developed on the right side. Beside, there is a loss of volumetric loss and a lot of scar on the left side. Though urodynamic did not give us a lot of information, the only thing is we can see that the compliance is normal. Now the child is on anticholinergics, crimafin, and antibiotic prophylaxis. She's repeatedly getting admitted for febrile UTI and on injectable antibiotics almost every month. So I will direct this case first of all to Dr. Pedro for to comment on what how
So,
things.
Pedro, just to add in the Rahul, sorry for that. This case we discussed in UCCon. As I told you, Asim Sukla was the international faculty, and Dr. Pathak is there to discuss with you. He is from Mumbai. He is also seen this case. This case is seen by me also, and this is a real-time case. You have two MCU to compare. Two decompression surgery, two reimplantation surgery, common sheath. One was robotic and one was open coins at the age of 2.5 or 3 years. Child is really suffering with the recurrent sepsis, multiple hospitalization for the IV antibiotics. So can you tell us, please, that what went wrong into this patient and what is the message to be taken and what we can do now?
That's for me, Anil?
Yeah.
My concern in that picture that you can see there is that in the VCUG of the 15 months, the contrast from the left reflux doesn't come out. So you can see that there's some kind of obstruction already at the 15 months because you can see the empty bladder, but you still have contrast in the VCUG in the left kidney. So maybe there was something that it was developed, and you can see at the end in the 5-year surgery that you still have contrast, even the bladder is empty. That's one concern. The other is that at some point, either cystoscopy or when you have the bladder open doing the coin, did you check what happened with the right ureter? Because your dilatation on the right ureter, at least for the images that you are showing, I cannot explain.
Right. But what about the your comment about the common sheath reimplantation extravasically done for robotically? Do you think such a dilated ureters can be taken extravasically without any tapering, just by doing the little more tunneling for the reimplantation?
Yes, we do. We don't tailor in or taper in any of the ureters when we do a Gregoire, because we know that we will not get, even if we don't get the 1:4, 1:5 relation that we need between the diameter and the length. In our hands, we don't have much problem without tailoring. But with the robotics, I have some issues with the robotics, even we are not using the robot as much of this, because it has been shown that the robotic surgery in VUR reimplantation has a more higher rate of obstruction because the knots get a little more tight than when you do it either laparoscopic or with the hands, because of the feeling that you are losing with the robotic. I know that there are experts in robot, and you can say, I don't know, Mohan Gandetti from Chicago, that probably you know all, very well. He's a very expert one, and he does it very good. But in a study that has been done a couple of years ago, you can see that the robotics, the obstruction rate in the robotic VUR reimplantation, it's higher than in the open traditional way. So maybe there's something there, could be. To do the tailoring or not, we are not fan of the tailoring. I know that there are people who does it. Either you take it out or you just flip it one side over the other, and then you have a more bigger ureter to just get into. So it could be an issue.
One last question from my side before I give it to the Chandra and Hemant Pathak sir. That do you think that there is some detrusor weakness along with the ureterocele? So when you do common sheath reimplantation after the ureterocele decompression, do you think that we need to address that detrusor weakness to have a proper result?
As I said in the presentation, when you will do the second procedure, you will do an open surgery or you will do the reimplantation, you have to go for the whole package. excite the URETEROCELE, reimplant, and reconstructs the bladder wall and the bladder
So
neck.
how it
because
can be achieved in extravesical, completely extravesical approach robotically? How it can be achieved?
I don't know in robotic. If I will do it
So,
open,
so Dr.
if I will do
Pathak
it
and
open,
Chandra, you can go ahead with your interaction with the PJ.
Yeah,
Pathak,
Dr.
sir.
PJ, thank you. Sorry, yes.
yes.
Yes, Dr. PJ, you mentioned about this. Yeah. Sorry, you mentioned about this extravesical for reimplantation for this. So do you ever consider an option of implanting one of the moieties into the other one and reimplanting just one of them? Just putting the upper into the lower and have just a single lumen to be reimplanted extravesically? Or do you try to reimplant both of them extravesically? What is your preference?
The first preference is to do it a double sheet, because you know that they share some vessels and some irrigation between one and the other there. So we try to don't separate both ureter to try to avoid ischemia in the long term. If you need to, because it's something that you have to resect, and then you are out of the bladder and you probably are short of one ureter and the other is longer, probably you can do a UU outside of the bladder and then reimplant just the other one inside. We have done that in a couple of cases with good results, with some scares in the follow-up because of this ischemic issue, but you can do it. And coming back to Anil's question, when you're coming from the outside of the bladder and you have to resect the URETEROCELE and reconstruct the bladder, you can do it because you open a little more the bladder, you work from there, not the whole bladder as a coin, you work from there, reconstruct the bladder wall, reconstruct the bladder neck, and then you do the extravesical closing a little bit.
Right. So message is very clear that we have to reconstruct the detrusor. That's a very important thing, to have a very stable reimplantation. Pathak, sir,
yes,
you go ahead with your question, sir. Interaction.
Good evening, Anil and Rahul. Thanks. Anil, what case you showed of a common sheath reimplantation with good results is a very technically very demanding. Is to what I feel, because what you are seeing here can be one of the scenarios which can happen in a common sheath reimplantation. That is a failed reimplantation, which giving rise to reflux. Second thing is, now my concerns are that we started off with a right side system, which was absolutely normal to begin with. Initially, yes, in the first week there was mild hydronephrosis, but after the ureterocele was incised, the hydronephrosis resolved, and now suddenly we are in a situation that the right kidney, which is normal, has become grossly hydronephrotic. The ureter is dilated. The bladder is appearing trabeculated. So something new has happened now after the reimplantation. That is, avoiding dysfunction has set in, where the bladder pressures are high and is affecting the right normal kidney.
Yeah, I agree with you, Herman. Even though I would like to have a really good look about that BUJ junction. If there's obstruction, if there's something, because sometimes you have an aperistaltic distal part of the ureter, especially when you have a duplex system, something like that. So probably that aperistaltic things, it's haven't had any issues when it was younger, and now you have issues when you have a 5 years old. And yes, there's something about the detrusor, but as Raul showed, there was no issues on the urodynamic study. So I would probably have a cystoscopy, try to get some catheter, try to get some contrast to the kidney, and see how that wash out at the end. If we have some delay there and we think that probably some kind of obstruction, you can either go for a balloon dilatation and just open that longer and bigger, or if you have concern because you have already compromised the left one, probably you would like to just go for the probably more successful surgery that is an reimplant in the right side as well. But it's something there that we haven't have a clue why in a 5 years time we have dilating and maybe losing some function of the right kidney.
Okay.
Anyone want to make a comment on this this case?
Yeah,
But sir. Yeah, but
yeah.
sir.
I think there are 2-3 issues. First is that when we are doing first time itself, what we have done the urodynamic, we should have the bladder function and bowel functions noted, and with the child should have been put on this one. Second one, I have my observations about this when we are using robotic and extravasically for such a large one. If we are using large amount of the cautery, that may really lead to the detrusor, some dysfunction later on, and that may be one of the causes. And second one is when we are using that the damage to the blood supply of the lower ureter is also has to be taken care, because when we are using robotic. And third one, which was pointed out nicely, the sensation and too tightening of the sutures, that could be the failure. But I have failed to understand why the second time sheath has failed. In that one, I think I would like to have a resection of the distal part of the common sheath first, because with the repeated surgery, distal part might have been compromised to have a good reimplantation. That's my comment.
So regarding the treatment, there was a suggestion from Luis before he left that what he said that if I am the treating urologist, I would put a catheter in this child, Foley catheter, and wait for 8-10 days, and will repeat the sonography study. If there is some decompression of the right kidney and some benefit seen also on the left side, then he said that I will seriously consider there is some bladder dysfunction, means the problem with the storage as well as the voiding pressure. You agree, PJ, with this?
Yes, I think it's a very good idea, because with that you run out of the equation what happened with the bladder, and then you will see if something really happened, and then you can just focus on the bladder. Now, coming back to Ami's suggestion about the resurgery again, probably I will not go for a reimplantation formal one, either Cohen or Gregoire. Probably I will go for a nipple, so you know that you just invert the ureter and do some kind of internal uterostomy. So you will have the VUR, but you're safe in the obstruction. So you cannot have all of them in the next surgery. You need to get out of one of the problem, and probably the obstructive problem, it's a more serious one than the VUR problem.
Thank you, George.
Anyone would like to comment on this particular case with the PJ want to interact?
Sir, can I ask something? Now,
Yeah,
as
go
the
ahead.
child is febrile and needing so many admissions, is there an option of doing a cutaneous ureterostomy on the left side, as there are floaters also seen on the sonography? Or that issue is means we will not consider making a cutaneous diversion at this point at all, as the child has grown up?
Probably, as I said, Raul, I will try to go for the internal uterostomy rather than an external one, especially with a 5-year-old child, because that means that you need to put that child either in nappies or just a bag or something that will be a little more discomfort for the normal life. If you do an internal one, you keep the disconstruction, probably you have a VUR, but also you have the cycling of the bladder coming and going. So I would rather go with that. And some kind of anti-reflux system could be these nipple things. The people from Indiana are very keen of that. So what they do, they took the tip of the ureter in the distal part, and they just flip over the ureter. And that kind of extra surround that you have in the ureter, you reimplant that in the bladder straight away. So there is some kind of anti-reflux system there. Now, if we come to the transplant surgeon, they just put the ureter straight as a chimney in the bladder, and they just go out away without any anti-reflux system. So there's no bad idea at the end of the day to just get that as a chimney or as a nipple and get out of the obstruction. But I will do that following Luis Braga's suggestion: rule out the bladder, keep a catheter in, either for the urethra or a cystofix, and see what's happened after 2 weeks of decompression. If something happened, then we have a bladder problem, and then probably it's not just surgery of the ureter plus the bladder. You know what I mean?
Fine. Yeah. Okay. Perfect. Prasanna, you can come in, and if you have a pick up some couple of good questions, you can. Prasanna, yeah, please.
Anil, I want to have one or two comments about that incision part.
Yes, go ahead, sir. We have a limitation of time. We have promised to our secretary, but
just
you
I'll
have to
pass
give
one
5
word
minutes to
only.
Prasanna.
Yeah. You see, now people are using laser for the incision.
I am also.
I think that is a very good idea. And another one is a puncture one. The only thing which I want to see, and because I came to see in the literature one of the report where there was the vascular damage to the posterior wall and extravasation. That was the report I read. Then I thought, you see, the best part is that if you are keeping that laser point, that may damage the posterior wall. So you can put this in the open end ureteric catheter so that your precision of the energy is very precise. Don't damage the wall of the bladder. That is what my contention was. Okay.
But why, sir, posterior wall? Why to actually, if we are really aware and we make the see that the child is well hydrated and some maybe
let me tell you, because Lopez is
and the bladder filling should be kept at the minimum or at the say you can halfway. Then you have a good ballooning of the ureterocele. You can get the
idea. What I'm telling
Pedro,
you, there are all
PJ can say. PJ, you can say a little bit more on this issue of damaging.
You are raised this question. I'll let you know. You see, when we are using the small fibers, and the small scope, so when we are giving incision just at the nick of that one, because that report says, it's not that the first report which has been published about the extravasation of the
I agree.
And presenting this one. So that is the caution one has to.
Perfect.
One is that the incision has to be a little bit up and there has to be punctures only. And third thing is that if you think that the fiber is not stable because a small fiber, then you can use the open end ureteric catheter so that the fiber is more stable and then you can use it. This is my.
Perfect. Prasanna, go ahead. Prasanna, you are not audible. You are not audible, Prasanna.
Yeah, so we have a couple of we have a couple of questions. So I'll pass on this question to Dr. PJ. So one of our viewers have asked, can non-functional upper moiety ever regain some function after ureterostomy on long-term follow-up?
I would say, Prasanna, it's a very good question, and we haven't seen that. Probably it's more theoretically. We can see lower dilatation and probably good image on ultrasound, but in the function thing, if you don't have a function before that, most of the time you will not have a function after that. So our aim is to decompress and to save as more cells we can save, but to keep safe the lower moiety most of the time.
Okay, thank you for that. The second question would be, would you perform a EC renogram or a DTPA routinely on follow-up after surgery, after your ureterostomy?
Not really. We did at the beginning because we were studying all this kind of approach or whatever. Nowadays, if nothing happened, probably will not do it unless something happened in the ultrasound or unless we have a new UTI. But if it's a straightforward case and a straightforward follow-up and a straightforward ultrasound, we will not do any other kind of that test.
Another question is that when you do a heminephrectomy, when you remove the upper pole, how do you ascertain that there is adequate resection of the upper pole, and how do you avoid bleeding when you go between the two moieties? How much of parenchyma to excise? And that's a tough thing.
It's a very good question, and that's one of the reasons why I don't like very much the heminephrectomy. So one of the marks that you can have is when you dissect both ileum and you have clearly the vessels of the upper pole and you clip them, you can see how part of the kidney become black or gray and the other one it's still pink. And then you think that there's a margin between both of the lower and the upper pole moiety. Sometimes not so clear. And then we start either with hook, high coagulation, or with ligature and just cutting and beating, cutting and beating. Long time ago, when I trained in Great Ormond Street, what we did was with one of these, what was the call of the proline endoloop, we tried to just get that and to avoid the cyst coming out and the fluid coming out and the blood coming out. In the follow-up, what we saw is the child that we used the endoloop, we finish up with a cyst over that where the upper pole was. So we finish that now. So what we do is just either we just cut it with a coagulation or we use the ligature, and after that we just put either some of this hemostatic flow that you can inject by laparoscopic, Surgiflow or any that you can have in India.
So do you think putting the omentum there would help?
I think that could help. Some people have done that. We haven't never done that.
Okay. Okay. So thank you, Dr. PJ. Over to you, Anil. Thank you.
So,
thank you, Professor.
It's over to once again. Thank you very much, PJ, for accepting our invitation, and we would like to have you again and again. We'll approach for that to you. Hopefully, you have enjoyed. You can have a last comment regarding your experience joining with us, and thereafter, Dr. Kesavamurthy will conclude the session.
Thank you very much, Anil, and thank you everybody for joining us. It was a Saturday morning for us, and I saw a lot of South American, Chilean guys joining us. Thank you for being here. And I know that for you it's an evening, a Saturday, so it's a tough day and a tough hour. And I think we have a really nice discussion for lovely case. And my final take-home message is that we all face the same issues and the same problem. Doesn't matter in what part of the world we are. So happy to join you in a new one, and thank you very much for the invitation.
I loved your precise comments. Once again.
Thank you.
So Kesav, over to you.
Thank you, Professor PJ, for joining us. And it was a wonderful, interesting discussion on the duplex system and the ureterocele. Thank you all the national faculty, and thank you, Dr. Luis Braga, for joining in. Now I would request Dr. Arun Chawla to make the closing remark. Over to you, Dr. Arun.
Yeah, thank you, Dr. Keshav. Many thanks to Professor PJ for making this evening a really academic one, a well-spent evening. I think a very nice lecture followed by two excellent case discussion. I think what Anil presented was index case and bringing the scenario a little too complex one. But the second case brought so many issues, I think very nicely discussed and with very quality comments from everybody, both the national faculty as the international faculty. Thanks to all the viewers who joined on Zoom platform as well as the YouTube platform. Thank you, everyone. Thank you, Anil, for scripting a nice program and your team. Good night. Over to you, Dr. K.
Thank you all.
Thank you all. Thank you.
Good night. Good night.
Thank you.
Looking forward to see you all again. Thank you.
Have a nice weekend.
Thank you.